Thank you very much, Reinhardt. I dread to think what the inappropriate pop songs were. Perhaps we can relive those later. Reminiscence is a great thing in dementia care, isn't it? And thanks, Chris. And also for the two previous speakers, really, for setting the scene to what I'm going to talk about today. The Meeting Centre Support Programme is a service, a support programme that's been going on in the Netherlands for about the last 15 to 20 years. And it's designed to help people within local communities living at home with family carers. So that's the area we're going to look at. This is actually a big research programme that I've got the privilege of being the UK lead for. Meeting Centre Support Programmes, as I said, started in the Netherlands, and there's a lot of very good stuff around dementia that's come out of the Netherlands. Those of you who've worked with dementia cafes or Alzheimer's cafes, it's that they're very good at the sort of normalising, integrated local support that really helps people continue to live the life that they want to lead. And this service was developed by Professor Rosemary Dreers at the VU Medical Centre. So the research is to take this wisdom from the Netherlands and to see whether we can translate it into three very different European countries: the UK, Italy and Poland. So the funding enables us to work for 3 years in each country, learning from what the Dutch have done, trying to set up a meeting centre support programme within our 3 respective countries, so to see whether it works or not, basically, and then to run that service for a 12-month period and gather the evidence to see whether it actually does have a positive impact on the lives of people living with dementia and their families. And in the UK, we're working with UCL and LSE, who are helping us particularly look at the cost benefits as well, because as we all know, we now have to prove that what we do is cost effective as well. Okay, so the Dutch story, you'll have to follow the little arrows around this slide. So started back in the early 1990s, particularly in Amsterdam, with a needs analysis study. So talking to people and families and also service providers to say, what would you need in your local community in order to support people longer term at home, living the life they want to lead? This led to a development of a meeting centre programme and a pilot study in the early 90s. They then did is there a pointer on this? There's a pointer. They then did a little effect study, so a sort of before and after, and comparing it to people who were getting the meeting centre to people who weren't. That then led to a larger study across the Netherlands, looking at 11 different centres compared to 11 different areas that weren't implementing the meeting centres. And that convinced the Dutch authorities that this was a cost-effective, good way of supporting people within their local communities, and it's now become part of the care pathway in the Netherlands. So obviously they have a very different insurance system to what we do, but going to a meeting centre is a legitimate thing to spend your insurance, your health insurance funding on. At the VU Medical Centre in Amsterdam, they then set up a help desk. They provide training and resource materials for any local community that wants to set up a meeting centre, and there's a very sort of set procedure for how you do that. So there's now over 120 meeting centres in different parts of the Netherlands and 20 more in production. And then we've got the Meeting Dem research project, which is this European project, to see whether we can disseminate this into different European countries. And looking at the evidence, these were the results of the initial Dutch multi-centre study. that found, compared to ordinary care, and in those days in the Netherlands that was fairly traditional day care, for people with dementia, they found that it decreased withdrawal, loneliness, isolation, but also some of the more sort of unsocial behaviours. It led to less depressive symptoms, higher self-esteem, and significantly a delay into nursing home admission. And they also looked at the impact on family carers as well. And for families, it led to less feelings of burden and less psychosomatic complaints, less poor health for family carers as well. So what our research will do, and going back to the evidence, it will help us provide evidence of what works. So we'll look at trying to set up a pilot meeting centre, look at the facilitators and barriers, what happens in the UK when you try and do something like this. We will be looking then at the efficacy, so whether it improves people's health and well-being, and the cost effectiveness of the meeting centre in each country. And also importantly, what we've just been hearing about, it will look at the service user satisfaction. So how does this impact on the lives of people living with dementia and their families? So we're halfway through this research at the moment. We have set up now 3 meeting centres, and I'm going to talk about those. We've done lots of stuff around user satisfaction, and people really, really like these. And we're just in the middle of doing the efficacy and cost effectiveness. So we're currently collecting our data on that, and we'll be reporting on it next year. So what is a meeting centre? I've put this slide up because this was the first English translation of a Dutch slide that I ever saw about meeting centres, and we've been working a lot, obviously, with English translations of Dutch language material for the development of this. So essentially, the meeting centre is both for the person living with dementia and for the family who are supporting. So it's a very quite different in some respects from how we're usually used to thinking about services that we provide that are for the patient over here and the carer over there. This is very much about recognising how people live together with their dementia. For the person living with dementia specifically, there is usually a social club that operates on 3 to 5 days in a non-stigmatising ordinary life setting. And what the Dutch say happens at the social club is psychomotor group therapy and creative and recreational activities. And I think we can translate that into things that help people, make people happy, keep people moving. So the Dutch, again, have always been very good at recognising that connection between mind and body, which I think, we know now for people living with dementia, very important to keep people physically active, but also recognising that creative and recreational activities are important. For the family carer, there are information meetings, lots of psychoeducational stuff, a specific support group for family carers, and care coordination. Because the groups are very local, it becomes a real good focus for knowing how I get services in my town, or how I work. If something's not working, somebody at the meeting centre will know somebody who knows how to make things happen. So very good local care coordination. For both the carer and the person with dementia, another feature is that there is a consulting hour. So usually with the centre manager, or what we've done in our services with dementia advisors or adult nurses, is a time when you can come together as a couple to talk about how it's affecting your relationship. So very much looking at the sort of counselling and psychological adjustment that people need to make. There is always a monthly centre meeting. So what happens at the centre, and particularly at the club, is driven by the needs of the people who are using it. So each month there is a very big formal meeting which is for people living with dementia, family carers and staff to review the programme and how's it going and what are we going to be doing the next month. And also a lot of social activities and celebrations. My reflection after, having worked with this model now is I'd like to draw out a few things that I think are different about it. It is a very local focus. So a typical meeting centre rule of thumb is that you look at a population of around 5,000 older people. That will give you a viable meeting centre. So the one that we've developed is in Droitwich Spa in Worcestershire, which is a fairly typical small market town. And I think often in health and social care in this country we tend to go county-wide. We think Worcestershire. And actually, people, particularly if they've got dementia, the social networks locally is what makes a big difference. So I think that's the first thing I'd pick out. This is something that focuses very much on a local community. The meeting centre operates on a small permanent team. So in our case now we have 3 members of staff who are employed, and although the centre only opens 3 days a week for the club, they work 5 days a week because they're working with people to help engage them with the service and also to do the planning. And there is also a big use of volunteers. So always, if you're using the meeting centre as a family member, there is, Rosemary Drewers would say, you always ask the family what else they can bring too. So that might just be making a cake once a week or doing the coffee or doing a piano session. So there is very much a ways of engaging the people within the meeting centre ethos as a volunteer. The centre is set in a non-stigmatising ordinary life setting, so a community centre, never a hospital, not a care home, not a hospice. This is somewhere where you go to do ordinary stuff. There is a strong structured person-centred programme of intervention and activity, both for the person living with dementia and the family carer, and it's based on something called the adaptation coping model, which I'll talk about in another slide. Okay? But everything that happens at the meeting centre happens for a reason, and that is that it helps people adjust and cope to living with dementia. There is in the planning cycle, so how you set a meeting centre up, there is also a very structured way of community engagement, which they've worked through in the Netherlands and honed now. So it's not just that the meeting centre has a structure, the planning has a structure, and how you engage and build it too. And I think that's different from things that we've used in the UK before. And it fits very well with post-diagnostic support. We've worked very hard on improving diagnosis in this country. But a lot of us worry that, hey, you get your diagnosis and then what? You have to wait till you get a really severe problem before somebody offers you a hand again, So it fits in that part of the care pathway. Dementia-friendly communities, dementia action alliances, those sorts of things. Okay, underpinning theory, the adjusting to change model. What Rosemary and her team have developed is this model that says if you are a person living with dementia or a family carer, there are a number of issues and tasks that you have to adjust to. And the theory is if you make a good adjustment early on, then later on you cope better for the longer term. So this would be things like obviously dealing with the disabilities that dementia brings, understanding what the neurological impairment is and how you deal with that, what the gizmos and gadgets you can use and the tips that you can use to help you get through life. Getting back on an emotional balance, recognising that a dementia diagnosis turns your world upside down and you need to get back to a state of equilibrium. To maintain a positive self-image, to integrate that diagnosis with who you are and to learn to like yourself again with that diagnosis. Preparing for an uncertain future. One of the biggest challenges of dementia is nobody can tell you as an individual how the next 5 years are going to pan out. And that's a really big difference to how most of us plan our lives. So learning to live in the here and now and cope with that uncertainty is one of the adjustments that people have to make. And also recognising that because dementia is progressive, chances are you're going to have to get used to dealing with professionals and having people talk to you about your personal stuff. You know, so it's a way of ensuring that you can do that. Okay, so we've opened these first meeting centres. Droitwich, we spent a year in the planning. You start off by calling a huge information meeting in your town, so you use your social networks to call anybody and everybody who might have an interest in dementia. You talk about what a meeting centre is and decide whether there are enough people who want to get one going. And that information meeting can be started by anyone in the town. You then form an initiative planning group who work through a series of stages to open a meeting centre. And that planning group, the initiative group of around 10 to 20 people, then becomes the advisory group once the centre's opened. So you continue that process of community engagement. Okay, I've just been shown the 5 minutes, so I'm going to move on a couple of slides. So that's the typical, that was our initiative group in Droitwich Spa. So it goes to show, you know, you've got your traditional sort of GP practice, NHS, but also the local solicitors, the Forum for Older People, community transport. You know, it depends who's in your town who will be interested in taking this forwards. In Worcester, which is a market town in Herefordshire, that was their initiative group and their advisory group. So you can see there's some similarities but some differences. And every meeting centre will therefore be responsive to the needs of that local community. Even though Droitwich and Worcester are only 50 miles apart, they're chalk and cheese, you know, and they have different ways of doing things. The key decisions in the initiative group are these. So who's the service aimed at? What are the inclusion-exclusion criteria? What's the programme consist of? Where are we going to hold it? Who are we going to employ? How do we fund it? How do we get cooperation between the different partners? So those key decisions, we've got loads of information that the Dutch have got that we have now adjusted for working in an English context. And as I said, some very nice early indicators. The clinician in me knows this works. The researcher in me has got to wait for the evidence on efficacy and cost effectiveness, of course. I am aware that I haven't got much time to talk about that, and I just want to talk about next steps. So next steps. We'll be completing our evaluation and reporting early next year on the formal cost effectiveness and efficacy. We are at the moment in the middle of running what the Dutch call pioneer workshops. So these are half-day workshops that are set up for people who want to build a meeting centre in their local community. We have one of those on April the 20th in London, and we have one on April the 24th in Sheffield. So if anybody's interested in those, they're free, then please contact me. And we will then, after the end of the research, be thinking about if this is effective, how we then roll that forward. But that would be your key way of learning about it, would be coming to a pioneer workshop and getting some understanding of what this is like in depth rather than just a quick 20-minute presentation. We're needing to operationalise the funding models. We worked with the Alzheimer's Society for the first two implementation, the first two meeting centres, and they very kindly have funded the first two so we can get them going. But it's enabled us to see how much they cost. And we reckon a basic meeting centre costs around £80,000 a year. Compares rather favourably with £11,000 a month. But, you know, that's 3 staff and a venue and your overheads. Obviously, you might configure it slightly differently. So it's now for us to think about, well, how do we fund those locally? What statutory funding can we call on? Might the local GP practices put something in, clinical commissioning groups, or local fundraising? And then to develop how we disseminate this into the future. So those are our next steps. Thank you very much for bearing with me.